Respected chairpersons, good afternoon, and good afternoon one and all assembled here. We all know that angiogram assessment is an extremely crucial aspect of a CTO PCI, and quite a bit of time needs to be spent on outside the cath lab rather than inside the cath lab to make this procedure effective and sort of have a very good result at the end. So owing to uncertainty of success because of the CTO, there's quite a bit of apprehension in embarking on CTO cases. So most primarily one need to, as Dr. Kumar mentioned, it's extremely important to clinically assess the patient, see if the patient would benefit from the procedure, and also enhance as much as possible the study of the coronary angiogram to be able to find a good result in the end. So why is it so important to have an angiogram assessed in a very critical way? You need to have a plan upfront. You got to have an alternate strategy in place because surprises are so common. You have to have some idea as to what the success rate from a certain case could be, and also go through what the poor predictors are in a given case. One should also may need to anticipate complications coming your way, and very importantly, cost assessment is very crucial. I was discussing with Dr. Surya Prakash at lunch that cost becomes an extremely important factor in CTO PCI. So certain aspects surrounding an angiogram, even before embarking on a PCI, it's critically important to have a contralateral injection, a dual injection, to enhance the success rates in PCI, especially and for sure at all times when there are contralateral collaterals. Because single catheter injections always allow suboptimal visualization of the entire coronary tree, and the ability to study the proximal and distal caps might not be as effective in a single catheter injection, and also the distal vessel assessment beyond the CTO may not be all that effective. And also occasionally you might find that the occlusion is actually not total, and it could be functional in a way that you could find a patent central microchannel coming up your way, and that's probably a functional occlusion that's picked up by a contralateral injection. During the PCI itself, a dual injection will help us position the guide wire in the right lumen, and obviously you've got to reposition in the right place before advancing a balloon or a microcatheter to prevent any complications like a perforation. And also, there can be ipsilateral collateral damage when you're manipulating the antegrade wire, and the collateral flow direction and the strength of flow can switch over from one source to the other, which will be picked up by a contralateral injection rather than an antegrade injection. If you're adapting a dissection or re-entry technique, inadvertent injections from the antegrade syringes can enlarge the subintimal space and make life difficult in maneuvering the guide wire through the right place. So it's suggested it's better to take the syringe off the antegrade port when that's being done, so that the subintimal space doesn't have a hydraulic expansion. It's again suggested the right coronary is engaged ahead of the left coronary, so that maneuvering or rather torquing the right coronary artery goes unimpeded. So, and also use low magnification so that the entire coronary tree is assessed when the injections are taken, and try and not to pan the table to facilitate recognition of collaterals. Obtain a long cine acquisition so that you will see what comes in late as in a branch or as in a collateral, so that you would have found the anatomy in full. Inject the donor vessel first, followed by the injection of the occluded vessel, and the donor vessel can be injected before the cine is recorded if the area of interest is the collateral circulation. So you can also inject through a single port. If you can adapt an 8 French sheath, femoral sheath, through which 4 French catheters can be taken in, and simultaneous injections of both coronaries can be accomplished through one axis. So one has to spend significant effective time to be able to evaluate the lesion, and if you can have an access to a previous angiogram, it's extremely critical to see them as well, because you'll have to know what came in new as against what's been there for a very long time. And obviously CTO is always a teamwork. The entire team has to go through the CTO angiogram, including the physicians, technicians, and fellows, and we all should try and get in as much input as possible from the team so that we have a strategic plan. There's no significant, or there is no fixed time as to how long one should see an angiogram, but then once the angiogram is the assessment is complete, we all should have a certain set plan as to how we are going to proceed and how we are going to strategize as we go along. So 4 key parameters are to be assessed in an angiogram: the proximal cap ambiguity, the lesion length, quality of the distal target vessel, and the collateral circulation. These are the 4 basic parameters one needs to look into in an angiogram. Obviously, the proximal vessel caliber, it will also help us guide as to what sort of guide support one can encounter, and whether the proximal cap is clear, whether the tip characteristics, whether it's tapered or blunt. I'm not going to go too much into detail. I think Dr. Surya Prakash Rao is going to say on the CTO assessment, lesion assessment. Is there a side branch where the stump is found, and the degree of calcification in the lesion itself, and the length of the lesion, and also the characteristics of the distal cap. What's the caliber and quality of the distal vessel? Is there a bifurcation? Is there another large branch coming off where the distal branch is? And also, is there a graft insertion site in the vicinity? So all of these parameters have so much of significance. It'll upfront tell you whether you're going to get the difficult path, or your procedure is expected to be intermediate or on the fairly easier side. So the entry shape, whether it's tapered or blunt, whether the calcification is present or not, whether the degree of bending is over 45 degrees or lesser than that, the point of occlusion, what's the length of the lesion, whether it's less than 20 millimeters, more than 20 millimeters, whether it is a second attempt or the first attempt, or several attempts have been made in the past. So all this will determine the bigger the score, then you're expected to have a long innings in the cath lab. So you can upfront know whether you're up in with a difficult procedure. Also, you can have a fair understanding according to the score. If the CTO score is 0, then little over 90% of the times you're likely to finish the case in less than 30 or 40 minutes. Or if the score is 3, then 1 in 5 times is what you'll finish the case early than late. Try and replay the cines as slow and as magnified as possible to have a complete understanding of the lesion. A quality angiogram is extremely critical. So one have to know where the origin and course of the collateral is. And occasionally one might need a coronary CT for very long occluded segments. So why is it so important? Because we'll have to map out all possible options, because there is very little time to think all the time in the cath lab. So if you've done enough homework within the cath, before the cath, then you also have a good strategic plan. You can actually jolt down a few points as to what your approach is going to be, what the lesion characteristics are like, what's the proximal cap like, what's the length we are encountering, how is the visibility of the distal vessel, what's the quality of the collaterals, and is the calcification big there or is manageable. And you can have the wire strategy, you can have what approach you want to embark on, whether you want to switch over to other special techniques. And the collateral vessels have to be assessed for the size, the tortuosity, and the angle of connection. Very critical points in assessing the collaterals. The favorable ones for the retrograde approach would be larger collaterals, lesser tortuous vessels, and the distal vessel connection from the collateral at an obtuse angle rather than an acute angle. These are most favorable for a retrograde approach. And this is extremely important. The presence of collaterals does not necessarily signify viability of the collateralized myocardial territory. So clinical assessment, even before the angiogram and during the angiogram and post-angiogram, one needs to ensure that there is viability in the territory one is trying to intervene. So some of the collaterals, the septal collaterals can best be seen in the oreocranial view. These are all optimal views. It can vary depending on the anatomy in a given case. And a straight orevo or a orevocaudal view to look at the collateral closer to the PDA, and most wiring attempts can be achieved in the LAO view. The epicardial collaterals in the lateral wall getting to the diagonal and the OM vessels are assessed by LAO-cranial or orevo-cranial views, and the ones with the proximal circumflex and the RCA through the epicaudal and the RAO views. Classifications, the collateral circulations will help us know, again, the difficulty that one can encounter or what sort of epicardial filling that the collateral vessels are offering. Thereby, one can plan the procedure. Similarly, with the Werner collateral connection, grade 0 is no continuous connection at all of the collateral, as against grade 3, where there's a more than 1 millimeter diameter of a direct connection of the collateral. Computer tomography is not always done, but it would be useful to have a CT done when there's calcification, tortuosity, and if there is a significantly long lesion. It may help in helping us get a best angiographic projection for crossing the wire, and occasionally it might pick up a stent that's sitting in the side branch that's probably not seen before. Dual artery access is most important for step for success in CTO PCI. Obviously, in all cases except absolutely there are no contralateral collaterals, then you don't have to have them. Most operators go by the bifemoral route, but then centers which have high expertise for through radial procedures can embark on biradial access. And if there is a very little chance that one would go a retrograde route, then you can have one femoral and one radial access. Long femoral sheaths, preferably more than 45 centimeters, is preferred for enhanced support and facilitate guide catheter manipulations. Occasionally, a triple arterial access might be useful because of the RCO CTA with an example like this, where the RCA is occluded and the LAD is supplied by the lemur, but the septal collaterals are coming off from the LAD proximal to the occluded LAD segment. So in conclusion, it's extremely important to understand the lesion characteristics of a CTO. Teamwork is very valuable. Spending significant amount of time outside the cath lab before getting in, knowing the lesion, knowing the plan, knowing the strategy, having alternative strategies in case you're stuck in between. And also, needless to state that a good preparation is extremely important to test in success. And of course, we all have to keep cost in mind because we'll have to speak to the family and also keep them at confidence before embarking on a CTO PCI. Thank you one and all for your valuable time.
Thank you.